Hi, everyone. I'm Dr. Chris Barrett, and tonight we're going to talk about an integrated approach to biofilm removal. I am a podiatric surgeon by trade, and at the moment, for the last 20 years, I jumped into the wound care space. So I am, at the moment, the program director for the Centers for Wound Healing at Crozier Health System, and that's located in Springfield, Pennsylvania. My disclosure. So this program is provided by the North American Center for Continuing Medical Education, NACME, LLC, an HMP global company, and it is supported by an educational grant from 3M Healthcare Medical Solutions Division. These are the learning objectives. So you're going to see the word bioburden and biofilm. So we're going to explain the effects of bacterial bioburden, biofilm, and inflammation on wound healing outcomes. It's going to really resonate throughout the entire discussion tonight. We're going to talk about employing immediate and long-term patient-centric treatment plans for managing not just bacterial bioburden, biofilm, but also inflammation, because they really do go hand in hand. And then we're going to explore case studies, look at case studies leveraging the use of 2 advanced wound care dressings that deal with this difficult challenge of both wound infection and bioburden, as well as the presence of wound inflammation. So, let's make it clear that removing biofilm is not only difficult, but it's unlikely going to happen with just topical application. It really requires a multimodal approach. So our discussion is going to highlight one treatment option utilizing 2 advanced dressings, current guidelines, and how we can integrate these products together with other interventions, with other primary interventions to achieve better outcomes and hopefully at a lower cost. Because I think you're going to see that the cost of our care is certainly a significant aspect of wound care, especially in outpatient wound care, where I've spent the last 20 years. So I think this is going to be certainly a key aspect, not just clinical applications, but also how we can save money. Okay, so we can't talk about bacteria or wound bioburden without including the effects of generalized and wound-specific inflammation. They're closely linked. They work hand in hand. Generalized inflammation is a result of chronic disease. It increases the risk of bacterial contamination, becoming wound infection, then moving on to biofilm, which in turn breeds a chronic repetitive cellular inflammatory response in the wound. So this is the challenge for us as wound care providers. So if we want to highlight how bioburden complications affect our patients' health, as well as our healthcare system, we need not look any further than surgical wound infections. So as you can see, 31% of all wound infections. I'm going to show you some data after this slide that really kind of demonstrates just the incredible impact that wound infections are having on our healthcare systems and our patients. But you also see not only does it increase patient mortality, but again, look at the cost. It raises per admission costs in the United States $20,000 to $27,000. And this was, just a few short years ago. We know that number is probably higher. It's also the most common healthcare associated infection monitored by the CDC. That's not the only part of the story. And this is kind of what I really want to key in on. For those of us who do wound care for a living, you may have seen and read the literature. You may have seen this, and I find it hard to believe that it's already now looking at 4 to 5 years old, this study, this publication. But in Value in Health, the Alliance of Wound Care Stakeholders, really headed by Marissa Carter, Marcia Nussbaum, Dr. Caroline Fife. And what they did was they went back and did a retrospective analysis of, this is 2014 Medicare data. So this is looking back, we're now going on 7, 8 years ago, looking at the prevalence and the treatment costs for one or more of all of these different wounds and wound complications. So if you look at the list, it pretty much encompasses everything you would see in terms of the wound care sphere. So all manner of wounds and their complications and infections. And here's the results, what they find. Not just that over 8 million patients in 2014 had at least one type of wound or infection, but look at the most prevalent groups, okay? Surgical wound infections, diabetic wound infections, most expensive surgical infections. But look at the spending. So we know, as I already mentioned, bacterial bioburden and the complications from wound infection and biofilm, we know are staggering to not only patients, but the healthcare system. But look at the money spent in 2014 dollars. If you look at total costs, and this is looking at inpatient costs, outpatient costs, physician costs, approached $100 billion. So imagine if you add not only Medicare costs, but the commercial payers. It's not unreasonable to think that we're looking at $200 billion treating wounds and their complications. But look where the highest spending is, in the outpatient areas. Okay, so this is the challenge for wound care providers. We know infections are not only costly and very prevalent, but the market is very, very diverse. Okay, and for a new provider, a new wound care provider, it could be very daunting. If you look at the wound care market share, antimicrobial dressings lead the market. Not unexpected, being that wound infections are such a chronic and difficult problem. And you look at the advanced wound care market, expected to grow year by year. So for a new clinician, this could be a very daunting challenge. Which dressings work the best? What do I choose? How do I make a decision? Okay, so this is the challenge for the outpatient departments. I'm the director of 2 departments, and in the last 20 years, I've seen tremendous changes in reimbursement and how the payers address outpatient wound care. And it's no wonder looking at this data. Wounds are a symptom of underlying comorbidities, of underlying disease. So the problem is the manufacturers keep bringing more advanced wound healing technologies to market. Not that that's a problem. There's some wonderful technologies. The problem is most of your commercial payers are very, very slow, as you've experienced, to approve these products. They tend to call products experimental for many, many years. So these products come to market, and the problem is, as wound care clinicians, oftentimes we can't utilize them for our patients. And oftentimes the conditions that they cover to use some of these advanced products are really for the most common wounds: diabetic wounds, venous wounds, pressure injuries. So the traditional way of providing outpatient wound care, that model, which is really focused on volume and profit, 20 years later after getting started, how is that working out? Not very well. Okay, so this is the challenge for those of us in certainly the outpatient areas, like our typical wound care clinic. So what do you do? What's your guide? What do you use as a guide or your therapy plan for a chronic wound? So we know that we have this, this diversity in types of wounds we see in our clinic. We know that the payers are restricting the type of wounds that they reimburse and the products they reimburse. So what do you use as your therapy plan? I like to go back to old school. I like to go back to 2003. And this is the concept of wound bed preparation. So the concept of wound bed preparation was originally discussed by plastic surgeons. The concept of wound bed preparation is preparing a wound bed so that you have a viable vascular bed that's optimized for the acceptance of a skin graft or your advanced products. So in other words, you want to have a viable wound bed so that whatever you choose to use to close the wound, and obviously there's a cost involved, will work. Okay, so that was the concept. And some of the key opinion leaders in wound care back in 2003 got together in a meeting, in a consensus group, and they took that concept of wound bed preparation and came up with the acronym of TIME. So what they did was they named the barriers, and that was the concept of wound bed preparation, addressing the barriers that are preventing the wound from moving onto proper wound bed preparation and closure. And they called this concept TIME, TIME being necrotic tissue, infection and inflammation, moisture imbalance, and the edge of the wound that's non-migratory. So this was 2003, and over time, and over certainly the last 20 years that I've been involved in wound care, this idea of TIME and wound bed preparation has constantly been updated. So if we look at the most recent updates, and this has been updated multiple times, it's been discussed, is TIME still relevant? And I think it's a wonderful tool. I still use it today, but if we look at the more updated versions of TIME, this is Timers, and this came out in 2019, which still addresses the 4 primary barriers of tissue inflammation and infection, moisture imbalance, and the edge of the wound, but then brought in regeneration, with advanced wound care products. But the 5th factor, which is really kind of, to me, what really we're missing certainly in wound care, and certainly the way we're going to be able to reduce costs and provide better care for our patients, and that's addressing social factors. And this was again in another version of TIME, the TIME CDSD clinical decision support tool. And this was also published in 2019. And this kind of similar to timers, really took time, okay, and time was a wound-focused idea. And instead of focusing your attention just on the wound, it actually put the wound down lower in the algorithm. So now what's most important, and I think what we're missing in outpatient wound care, and this may seem like fantasy, looking at how we are still, really outpatient wound care is still all about moving patients through the clinic. It's about volume. It's about profit. What we really need to do is step back and do a better job with patient assessment, okay? Being more patient-centric. The problem with that is that's obviously going to take more time. So volume is not really going to be the focus. The focus is on better quality of care, which ultimately should reduce costs. So instead of focusing on the wound first, what we do is assess the patient. A, assess their well-being. B, bring in a multidisciplinary team. Bring in the specialists that we need to bring in to optimize the patient. That's holistic patient care. Then C, control or treat the underlying causes or barriers to wound healing. These are the things that we're not seeing in the wound care clinic. This is what's happening at home. Okay, these are the issues where, whether it's we need to bring in a psychiatrist, a psychologist, somebody to deal with depression and anxiety. Do we need to bring in a prosthetist? Do we need to bring in somebody to deal with incontinence and nutrition? These are all the things that we really are missing in our volume-based outpatient wound care world right now. So this is a new idea. Certainly it's kind of come to the forefront that we need to definitely get involved in more holistic patient care. But then you go down to D, and that's deciding the appropriate treatment. That's time. Okay, that's our wound focus. So if we look at time, okay, specifically, again, in our wound focus, I'm going to focus in on the I in time, infection and inflammation. Now, I said back in the beginning of this discussion that wound care, and certainly biofilm-based wound care, is a multimodal approach. So before we talk about anything, certainly after the holistic patient care and assessing the patient, getting the proper diagnosis, certainly as we address biofilm and we address time and the chronic wound bed, we know that our interventions, before we can use our proper interventions, and what really is the goal of our interventions, this is wound bed preparation. Our goal is to move this wound stuck in inflammation on the proliferation so that we can then move on to closure with our interventions. And certainly debridement, okay, because we see the T in time, non-viable tissue, a non-viable wound edge, biofilm. Really the foundation of good wound care starts with, good basic debridement skills. Okay, so there are multiple ways of debriding a wound, whether it's ultrasonic, larval, certainly sharp debridement, chemical debridement, mechanical debridement, but certainly effective debridement starts with, I believe, sharp debridement in an outpatient clinic or inpatient side, but certainly the easiest way to provide immediate and effective debridement is certainly by sharp debridement. So that's kind of where we start. But after we've done that, after we've addressed T, the non-viable tissue, we can look at infection and inflammation. This is, to me, is the most difficult area in wound care, certainly the most difficult area in the time framework. And the recommended intervention is antimicrobial. Okay, so there's two questions I want to answer for the rest of this discussion. Number one is, how do we determine when the wound is infected? Okay, what do we use as our guide? And then what I'm going to answer second, later on in our discussion, is what antimicrobial and what anti-inflammatory is best. And certainly we have a list. There's not only one, but we're going to highlight two effective advanced wound care dressings in this discussion that we can use to address not only bioburden and biofilm, but also inflammation. So to answer that question, I like to use the wound infection continuum for its simplicity. So the continuum provides a framework through which the impact of microbes have on a wound can be conceptualized. Okay, so the stages in the continuum describe the gradual increase in the number and the virulence of microorganisms together with the host response. So we know that early on, as bacteria contaminate a wound, they're non-replicating, or they're replicating, but not causing any effect on the host and the wound or wound healing. So as we move from contamination up to colonization, the wounds are replicating, but again, the wound healing has not been disturbed. Wound is still progressing. The problem is when we move from colonization to localized infection, okay? And the type of localized infection we're talking about is in the superficial compartment. Okay, so local infection, this stage has been probably the area of the most debate by wound care clinicians. There's terms that are synonymous with localized infection that you've probably heard: covert infection, critical colonization, occult infection. And regardless of the term used, it's widely accepted that a wound with microbial imbalance, with infection, exhibits subtle or occult or covert signs that experienced clinicians should be able to pick up before the classic signs or the overt signs, the spreading infection, the systemic infection, are seen. Okay, so this concept of localized infection, covert infection, subtle infection that experienced clinicians really need to be able to identify a wound before it becomes a deeper seated wound, or a wound that's a spreading infection or a systemic infection. These are the subtle signs that some of the experts said a good clinician should be able to pick up early on, just by good examination and good experience and good diagnostic skills. Hypergranulation, friable granulation, these are all things we certainly see on a daily basis. Epithelial bridging, pocketing, breakdown in the wound bed or enlargement, delayed healing, increased pain, certainly a signal, especially in your diabetics, and increasing malodor. That's one sign that I think we can key in on that really differentiates a wound that's infected or has a high level of bioburden versus a wound that's inflamed. We all know the classical signs of wound infection. We should all be able to obviously diagnose a wound that's infected. It's these covert signs that are more challenging. And this is really where the wound infection continuum kind of conceptualizes that idea that these covert signs, we have to be able to recognize these and intervene with our treatment. The question is, what do we intervene with? So this is the updated version. So you saw the 2008 version, and that was from the International Wound Infection Institute. So in 2016, they published their updated version of the wound infection continuum, and they had some additions and some retractions. So one of the first things they did was identified what the intervention should be. So obviously, we know with antibiotic stewardship, the overuse of antibiotics and resistance, we have to choose wisely when we introduce an oral antibiotic or an IV antibiotic versus a topical intervention. And certainly for a local infection, certainly an occult infection, we see those subtle signs. The recommended intervention is what we're going to discuss tonight. We're going to discuss one advanced wound dressing, one antimicrobial advanced wound dressing that would fit in this continuum that we can use to effectively treat localized infection or subtle infection or covert infection. One of the other things they mentioned was, let's remove this term critical colonization. I still hear this term today. The problem with critical colonization was the experts could not define it. Okay, they couldn't come to a consensus on what critical colonization was. So by that, they decided to remove it from the lexicon. Okay, so we no longer should be calling that covert or subtle infection critical colonization because we don't know what that means. And lastly, they bring in the term biofilm. We all, that term is now ubiquitous. All the dressing manufacturers, anybody bringing an antimicrobial dressing to market, certainly their target, their focus is on dealing with wound biofilm. So this is the big problem with wounds today that wasn't in existence in 2008. And this is what they mentioned. Again, it's very subtle, and we certainly have to, again, experience will certainly dictate how we can determine if a wound is infected by biofilm. And these are all some of the signs that we would see. And again, some of these are similar to standard wound infection or a covert or a subtle infection, but certainly when your antibiotic treatments are failing, or you've used the proper antibiotic and you're not getting the response you expected, recurrence after you stop antibiotics, these things all point to possibly wound biofilm. And what is wound biofilm? We should certainly all be familiar with that now. We now know that bacteria behave in a certain way. They no longer want to remain isolated. They communicate. They actually change not only the way they communicate, but the way they behave, called quorum sensing. So that desire to form a community, and then they protect themselves with this polymer matrix made up of proteins and polysaccharides and DNA. And that protection, that protective matrix or glycocalyx is resistant to most of your topical antimicrobials and topical antiseptics, your antifungals, and many antibiotics. The problem is bacteria in the center of the biofilm are metabolically inactive. We know our antibiotics really target active bacterial cells. So The problem with bacterial biofilm is if we introduce these topical interventions without dealing with the polymer matrix, the EPS, okay, that protective shield, then we increase costs because we know these products aren't going to be effective. How we make our products effective is by disrupting the biofilm. And we can do that, again, I mentioned the importance of good quality debridement early on, okay? Because the problem with biofilm is after you destroy the biofilm, after you destroy the matrix, it takes typically 2 to 3 days for the bacteria to reform the biofilm and become mature again. So if 80 to 100% of our chronic wounds are affected by biofilm, and they only take 2 to 3 days to reform, we know that if we see our patients more frequently, and certainly once we disrupt the biofilm, we have a window of opportunity to bring in topical intervention. Tonight, we're going to talk about a topical antiseptic, a topical antimicrobial that we can use that's effective to prevent biofilm reformation. And that's really the key with these products, not to destroy the biofilm, but to take advantage of that window of opportunity to prevent the bacteria from communicating and reforming biofilm. So what I'm going to look at tonight is, here's a list from published in 2016 along with the updated wound infection continuum. And this is by the IWII, the International Wound Infection Institute. And they looked at all the evidence and gave us some good evidence-based choices for topical antimicrobials. Now, most of these you've seen. I pretty much used all of them. There's one of these products that's isn't in the US at this time, but all of these products are very similar and available to us. So certainly there isn't only one effective antimicrobial agent, but I want to really concentrate on silver because that's going to be the focus of our product tonight, our antimicrobial product. And really, if we look at all of the antimicrobials that we have in existence, when I got into wound care 20 years ago, silver was just coming to market as an antimicrobial. So silver has really been the workhorse for antimicrobials, certainly in the wound care space. So I want to focus in on all the different types of silver that we have available to us and how they compare. Okay, so you see this list of the different types of silver. Okay, these are all very common silvers that have existed over the years, certainly over the 20 years that I've been in wound care. But I want to show you something unique. So the silver product that I want to talk to tonight is very unique. Okay, it's a product that I first became introduced to several years ago and became very interested. And this is a product that I now keep in my wound care clinic. It's called AG oxysalts or silver oxynitrate, AG7NO11. This is what makes this product very unique. So here's the compound. When this compound is introduced to heat or water, i.e. the wound bed, it's broken down into an oxygen couplet and Ag+1, Ag+2, and Ag+3 ions. Now, you know that all other silver compounds in the market are Ag+1, okay? What's the difference between Ag+1 and Ag+2 and 3, having 2 extra electrons? You can kind of look at those electrons as energy, as power, and you can see they have an electron potential. So instead of just having one small pull, one small electron potential, you have 2 other Ag+2 and Ag+3 ions that have a very, very strong pull, a very, very strong affinity to seek out electrons to replace them in their outer shell. The other beautiful part about this compound is that oxygen couplet can be used by the wound to improve wound healing. So what they found in further studies is wounds that did not have bacteria involvement, did not have bacterial bioburden, by introducing silver oxynitrate, they were actually able to improve wound epithelialization and wound healing without the presence of bacteria compared to other wound care products. And that's because of this dissociation and production of oxygen. And we'll show you a little bit later how that compares and how that looks in terms of comparing it to other wound care silver products. So this is a classic oxidation reduction reaction. If you put this into animation, this is what happens to our silver oxynitrate. So you have 3 electrons. Okay, again, those electrons are energy, they're voltage. And what those 3 electrons are looking to do is replace their outer shell. And they find those electrons from the bacteria. So the beautiful part is you have 3 pulls, not just one very small Ag+1 pull, but you have 3 pulls, 2 very powerful pulls along with your Ag+1 pull. that results in a very strong and a very powerful silver product. Okay, and obviously, because you have such a strong and powerful agent, you don't need as much of the silver to produce the same kind of effect. So you can use a lower dose of silver, okay, a safer and lower dose of silver to get a better effect, a stronger, more powerful kill with bacteria. And that's really the beauty of AG 7 and 011. Now, I showed you all the different silver products that on the market and really what makes this product unique. And this was really the study that keyed me into the advantage of having a product like silver oxynitrate. So when they took silver oxynitrate and compared it to some of the other metal compounds, and remember that for a silver product to be antimicrobial, to be effective in your wound care dressing, it has to be in ionic form, okay? But they looked at the various metal compounds, the various silver compounds that you would find in wound care, compared it to silver oxynitrate. Here's what they found. Number one, as we know, silver is an effective agent at eliminating planktonic bacteria. But we know the real key and the focus and what really makes a dressing effective is how it deals with bacterial biofilm and biofilm disruption. So what they found with silver oxynitrate is not only did it prevent biofilm reformation, but in their lab, it actually eradicated large parts of an established biofilm. So it reduced the biomass of a biofilm. But more importantly, and this is really kind of the key for me, is because of the higher oxidation state of the silver, because it's not just Ag+1, but it's Ag+1, 2, and 3, because of that power, you don't need to use as much. So it had a minimum bacterial concentration and a minimal biofilm eradication concentration that was twofold lower than other metal compounds. So in other words, you didn't have to use as much to get a more effective kill, as I mentioned earlier. So comparing this to some of the other silver dressings that are on the market and that you may have experience with, silver oxy salts, again, the silver content, very low, much lower than the other products on the market. But look at the 4-hour silver release. Again, a very high kill rate at a very low dosage, okay, and 5-log reduction in Staph aureus. So that's really the advantage of silver oxy salts, okay? Lower dose, higher kill rate. And the other part of this is, I mentioned oxygen. So this is how this unique product works differently than all the other silver products on the market. So we know hydrogen peroxide, okay, in low concentrations, certainly produced in the wound bed as a reactive oxygen species. It's certainly good for reducing inflammation and cellular killing, but in chronic wounds with excess levels, it creates a hostile wound environment and it breaks down tissue. So we know it's important for inflammation, for recruiting inflammatory cells, for killing bacteria, but at some point it needs to reduce itself to get that wound to move on to proliferation. The problem with excessive amounts is, again, we cause repetitive inflammation, which prevents wound healing. The beauty with silver oxynitrate, with our antimicrobial product that we're discussing, when it comes in contact with hydrogen peroxide, it breaks down hydrogen peroxide into oxygen and water, okay? Again, this is oxygen that the wound can actually use for healing purposes. There is no other silver product, no other silver dressing on the market that can make that claim that offers that benefit. So again, you have a product that's not only very, very effective antimicrobial, but actually produces oxygen by its breakdown and by breaking down excess hydrogen peroxide in the wound bed. So if you look at our time principle and the barriers to wound healing, our silver oxynitrate dressing can not only affect bacterial bioburden, biofilm, prevent biofilm reformation in conjunction with other interventions, reduce inflammation, address wound infection, and also manage exudate. Because when you put that silver compound into, say, a CMC substrate or carboxymethylcellulose substrate, it absorbs, it quickly absorbs, holds onto a large volume of fluid. The beauty is it also contours to the wound bed and prevents maceration, all the things that we want to see in an absorptive dressing. But at the same time, you have the advantage of a very strong antimicrobial dressing. So this is an ideal marriage of gelling technology to manage exudate and a high bacterial kill rate. And obviously, this is the type of dressing that you want to use to get your wound out of inflammation, break down biofilm, prevent it from reforming, and then have your wound progress on to proliferation and closure. But don't forget about inflammation. Okay, I said from the beginning, inflammation and bacterial bioburden and biofilm work hand in hand. They're linked. Okay, so when my group got together, we had a consensus panel meeting with some KOLs to look at this idea of wound infection and inflammation and how they're related and how we can differentiate the two. Okay, because obviously we can have a wound that doesn't have bacterial bioburden anymore, but still have high levels of infection that are preventing a wound from progressing. So if we have a wound that has a high level of inflammation, but doesn't have any microbial bioburden, how do we make that decision? How do we diagnose that? And that was really, when our group got into this discussion, we really had a lot of questions, and this was a very difficult question to answer. How do we differentiate? So this is the role of inflammation. So we know there is extrinsic sources of inflammation. That's obviously wound infection, okay, which oftentimes mimics the intrinsic sources of inflammation, which would be patient comorbidities, so uncontrolled diabetes, cancer, aging, hypoxia from, say, COPD, peripheral vascular disease, and pressure. Okay, so both of these, both the extrinsic and intrinsic factors, can produce inflammation. The way our panel really looked at this and said, there is a way of really distinguishing. Probably the key way, and I mentioned this earlier, is looking at, is malodor. Okay, certainly that sign, and maybe not so subtle, but that sign certainly differentiates a wound that may be infected versus a wound that may be inflamed. Some of the other things we discussed that may help us kind of in this differentiation between infection and inflammation is swelling that doesn't resolve, inflammation, okay, or erythema around the wound that doesn't resolve over time. These are certainly kind of indicators to us that the wound is likely infected and not inflamed, or at least infection is really the driver in preventing the wound from healing. So if we go back to our time principle, they even mentioned back in 2003 that it's not just infection, okay? Inflammation outside of infection can certainly be an issue, can certainly be a barrier. And their recommendation is to lower protease levels. Okay, so we know that chronic inflammation obviously oftentimes is driven by matrix metalloproteases and serine proteases. The experts recommended that we reduce protease levels to see if we can get the wound out of inflammation and moving on to proliferation. So again, what do we choose? Okay, what's the best dressing? What's the ideal dressing to address this problem? So we're going to use evidence. So let's address inflammation using the evidence that's available. So we know that in the non-healing wound environment, in a chronic wound environment, we're dealing with excessive inflammation. So high levels of protease activity, both serine and matrix metalloproteases, high levels of reactive oxygen species, inflammatory cytokines. What they do is not only do they destroy growth factors, which we need to recruit wound healing cells into our wound bed, but they damaged our native extracellular matrix. Okay, that matrix is a source for migration and for signaling. So this high level of inflammation is not only destroying our extracellular matrix, but it's causing cells to become senescent. Okay, they're sleeping, they're not doing their job, and that results in very low metabolic activity in the wound bed. Okay, so this is the stalled wound. So in this stalled wound, the negative factors, high levels of proteases and high levels of inflammatory cytokines, outweigh the positive factors. So we have a stalled wound. Okay. Brita Cullen, in her studies, early studies back in 2002, looking at protease levels and how to address protease levels, found that in venous leg ulcers, diabetic foot ulcers, and pressure injuries, MMP2, MMP8, and MMP9 were really the most common matrix metalloproteases in higher levels that were really causing wound chronicity. Okay, and these were the cells that needed to be addressed with the product she was developing. And this is the results of her work. This is Collagen ORC and Collagen ORC with silver. So this dressing, and we're going to focus tonight on Collagen ORC with silver, is 55% type 1 collagen, 44% oxidized regenerated cellulose, and there's 1% silver. So if we look at The collagen ORC without silver, it's 55% collagen and 45% oxidized regenerated cellulose, or ORC. Okay. And this is the beauty with this product. This is kind of what the research found is oxidate, we'll just call it ORC, is made up of cellulose. It's basically cellulose, which is a major component of all plants. So it's natural. And once ORC is oxidized, and if you've used this product, it's completely resorbed by the body. So it degrades, it gels. Okay, so obviously it provides a moist wound environment, trapping moisture, but it also scavenges free radicals and it binds, excess metal ions. And that collagen and that ORC stimulates cell migration and growth, which is certainly important, which is certainly what we're losing in a high inflammatory environment. So by reducing protease levels as a sacrificial substrate, your proteases attack your wound dressing. Okay, they attack our ORC and our collagen, and they allow our growth factors to reset. Okay, they allow our extracellular matrix to rebuild. Okay, and that's really how we use products like collagen ORC and collagen ORC with silver. Highest level for any collagen dressing, the most RCTs supporting its effectiveness. And this is the other beauty of having a dressing, not only that can address high levels of inflammatory proteases, but also has the benefit of the optimal dose of silver to provide a benefit in terms of antimicrobial benefit, but also not to interfere with cell growth. And so this product has a very low dose of silver, but in their studies, obviously you see that for most of the important bacterial players in the chronic wound, it was able to provide reduction bacterial levels of 10 to the fifth power or greater. So this is that kind of ideal level of both antimicrobial and anti-inflammatory action all in one dressing. And in the pivotal DFU study, Finn Gottrup found that DFUs achieved a significantly higher reduction in wound area, greater than 50% versus the control at week 4. So we obviously look for that target, at least in diabetic foot ulcers, of 50% healing at 4 weeks. So what they found was collagen ORC and silver, significantly better, 79% versus 43% for this study. And at week 14, at the end of the study period, 52% of the wounds were healed versus 31% in the control group. In this study also, which was really very interesting, patients in the collagen ORC silver group, nobody was withdrawn due to infection, whereas 33%, a third of patients in the control group had to be withdrawn due to infection. So that's again, the effectiveness of that 1% silver, an ideal level of silver. And what Brita Cullen found was that earlier treatment with collagen ORC improved healing in venous leg ulcers. So if you used it prior to 6 months, if you didn't wait up to 6 months, if the wound was treated with collagen ORC prior to 6 months, 73% wounds were healed versus as you add time, fewer wounds heal. So again, earlier treatment, being able to deal with not only bacterial bioburden, but inflammation and high levels of proteases resulted in faster and better wound healing. So my colleagues and I, at the end of our discussion, our consensus group came up with this decision tree. Okay. And what this does is really, if you ask the question, when do I use these products and how do I use these products? When do I bring them in? We tried to use this decision tree, introduce it to give you a little bit better understanding of the algorithm. So obviously we take our patients, and number one at the very top is good quality patient assessment. Okay, and this is that holistic approach that we really need to do a better job with. So once we assess the comorbidities, we get the proper labs, we do a proper HMP, we get the right diagnosis, we then risk stratify them based on the comorbidities, the number of comorbidities, what their blood work looked like, and psychosocial issues, those patient-centric issues. So from 0 to 1, we put them in the low risk group. We had the moderate risk group, and then the red group, group 3, the high risk group. Okay, so what you do is as you move your patient down the tree, we look at, are there signs of inflammation? Yes or no. So obviously, if there's no inflammation, we just could do basic standard wound care because these are low risk patients with a fairly good wound, with a fairly healable wound. But look at your yellow group and your red group, so your moderate and your high risk group. So we look, is there non-viable tissue? Then we clean up the non-viable tissue. Debridement, as I mentioned before, really the standard. If there's no non-viable tissue, then we can look at, is there bacteria? So first we start and look at, is there bacteria? Is there an odor? Is there excessive exudate? Some of those subtle signs, those covert signs. If there's a heavy bioburden, then obviously we want to bring in our AG oxysalt dressing to deal with that. If there's a low or moderate bioburden, we have that very effective anti-inflammatory dressing with 1% silver, Collagen ORC with silver. That would be the recommended dressing. If there's no sign of bioburden at all, then we can move right to the Collagen ORC dressing. And this is kind of the algorithm. This is the tree. This is a guide to how you can use these two quality dressings, dealing with the infection and inflammation, the I in the wound bed preparation model, to again, improve your wound healing, and hopefully by making quality choices, reduce cost as well. So this is really the goal. It's moving our wound from inflammation, whether we're dealing with bacteria, whether we're dealing with high levels of inflammatory proteases or both. It's moving our wound from inflammation onto proliferation and onto closure using good evidence-based AWD choices. So let's talk in the last 10 or 15 minutes that I have. I'm just going to show you some of my case studies using these products. And again, kind of using them, using that algorithm, making good choices to move stalled wounds, suspected of both bioburden and inflammation, get these wounds onto healing. So this was a gentleman, 61-year-old, who came into the clinic. Now, I didn't see this patient originally. This patient injured his leg, worked on, he's a mechanic, so he had a leg injury, came into our clinic 3 weeks after suffering the injury. History of rheumatoid arthritis and hypertension, well controlled. Problem is he smoked a pack a day. And here's the other problem. You have to look at the patient's insurance. He had a very high per visit copay. So anything we wanted to try, any procedure we wanted to do came with a high copay, which obviously affected his decision-making. And this is that, holistic patient-centric approach. We have to kind of take into account, not just, we can't focus on the wound, we also have to bring the patient in to the equation. So he didn't want to get hit with a lot of difficult copays, certainly understandable. So when I saw him, this was how the wound originally looked when he first came into the clinic. And the physician treating the patient was using debridement, sharp debridement, mechanical debridement, chemical debridement, was using silver sulfadiazine, one of the other silver antimicrobial options, and a dry stale dressing. So what happened was, this is what the wound looked like 3 months later when I was asked to evaluate the patient. So what we have is a PAR, or percent area reduction. So basically length by width of only 3% change after 3 months. We obviously know that this is a stalled wound, and that's not very good. So this is when my recommendation was to bring in the silver oxysalt dressing with the CMC. And the reason I did that is looking at the wound, the quality of the granulation tissue, the wound looked a bit desiccated. I think the dressing frequency was too much. You can see there's some peri-wound erythema as well as some irritation from the dressing. So my recommendation was, let's use a CMC and silver oxysalt dressing and change it less frequently so we can manage exudate better, but also provide, again, the antimicrobial action, because looking at this wound, my feeling with the epibole, the rolled skin edges, that this was a wound that's obviously affected by biofilm. This is day 1, 11 days after starting silver oxysalt. We see the wound is more moist. The granulation tissue looks a little bit more robust. The peri-wound erythema has decreased. So we changed our dressing selection, which obviously helped protect the patient's skin better. After 4 weeks, this wound had made tremendous progress. So unfortunately, we had transitioned the patient to Collagen ORC with silver at this point. He only came in for one more dressing change. The wound was about half the size that you see here on the right. And unfortunately, we lost the patient. We did contact him later, and the wound went on to complete healing. But the focus of these slides is to show the difference after 11 days of bringing in a more effective antimicrobial, a more effective silver. Okay, so obviously the silver oxysalt was more effective at not only addressing bacteria, but preventing biofilm reformation. And we see the wound then went on to progression. So the second case is a post-surgical diabetic foot ulcer. So this was a 57-year-old gentleman who had a right first ray amputation. So this is your typical, you're diabetic with hypertension, an A1C that's obviously high, but certainly not as high I've seen in some of my uncontrolled diabetics. He had negative pressure wound therapy applied by the referring podiatric surgeon. So this gentleman was sent to my clinic, sent to my area for hyperbaric oxygen therapy. So just as background, patients who come in for hyperbaric oxygen therapy at my clinic, I manage their wound care. So when this patient was sent to me, I'm looking at a patient who had stalled healing after 3 months. So just to give you an idea of what the wound looked like, I looked at the clinical records from my other clinic, and this is what the wound looked like initially after his ray resection when he first presented to the wound care clinic. And this is after 4 weeks of a silver hydrogel and negative pressure wound therapy. Okay, so a 4-week PAR, and again, for a diabetic foot ulcer, we'd like to see that approaching 50%. This was 22.4%. So we see not very big change in size. Granulation tissue is fairly healthy, but we have a wound that's just not progressing. Okay, so when he came for hyperbaric therapy, my first choice was to start the silver oxysalt gelling fiber dressing. We have a stalled wound, obviously biofilms involved. And again, you have a wound bed that really needs, moisture needs to be managed. So fewer dressing changes, but obviously being able to provide the proper antimicrobial with fewer dressing changes, better for the patient, lower cost, more effective bacterial kill. So this is what the wound looked like when he started hyperbaric and when I started silver oxysalt, 4.1 by 4.3 by 0.3. This is after week 4. So this is what I'll say is more like it. So we have at 4 weeks, we have a PAR of 69%, wound significantly smaller. And at this point, my feeling is we've addressed the bacterial bioburden. We have a progressing wound. So I'm going to move that patient from our silver oxysalt CMC dressing onto collagen ORC and silver. Okay, so this is when I transitioned him. And after 6 weeks, 2 more weeks, we were down to a PAR of 83%. So this is a wound that's now on its way out of inflammation on the proliferation. And he went on to complete healing and had a very nice result. So our third case is again, another trauma wound of the leg, probably one of the most common wounds that I certainly see and we certainly see in our clinic. So this was a 68-year-old gentleman who, again, had some leg trauma, right lateral leg, several weeks prior to his coming to our clinic. Past medical history, liver disease, hep C, cirrhosis, hypertension, did have a liver transplant a few years earlier, and previously had a skin graft on the right lateral leg. So this was kind of the challenge in that this wound was within that skin grafted area. So with scar tissue and the quality of the tissue from the previous injury and previous skin graft made it a more challenging wound. And he also had a right saphenous vein ablation for venous insufficiency. He was on tacrolimus, and his ABI was 1.28. So he actually had good perfusion, which was certainly welcome. So what I wanted to show you, and this is a short case, but I was asked to take a look at this wound, and my choice for this, again, if you can see, his peri wound is relatively intact. Wound measured 7 by 5 by 0.2. The problem was I didn't like the appearance of the granulation tissue. You can see it's very, very dull. Inconsistent. So my choice was, again, to go under compression and to be left for a week. The beauty is I can use this CMC dressing with the silver oxysalt, so I can provide both moisture control and the antimicrobial action of silver oxysalt. And then we put this patient under compression, and you can see I used a bordered foam dressing. And this was 1 week later. Okay, so all I want to show here is look at the quality of the granulation tissue. Certainly, I think by reducing the bacterial load, again, we have a wound that's now kind of rebuilding itself, rebuilding that ECM, lowering the inflammatory mediators. So we have neovascularization. We have a better looking wound. Okay, and this wound progressed. Unfortunately, this picture was by one of my nurses, so not good quality. But again, what I wanted to show you is in terms of wound size, we had a PAR of 58%. So the wound is reepithelializing. You can see there's no depth. It's actively epithelializing, and he went on to closure. But again, in a very short amount of time, we transitioned at this point off of the silver oxysalt and CMC dressing onto collagen ORC. but that's the effectiveness of our antimicrobial dressing. Does its work very fast, again, and that's kind of the goal, is to get your change fast enough that we don't need as many dressings, get the patient healed faster, obviously reduce costs. Very similar to the very first patient who had a very high copay. Again, we're not able to do expensive interventions, but we were able to get him a good outcome just using a good quality antimicrobial AWD. And then the last case I want to show you is a recent case of mine. This was a 64-year-old male who, a very brittle diabetic, who had right foot gangrene. He had fourth, fifth ray gangrene, he had resection. He had failed an angioplasty, so required a FEM-PT bypass. So thankfully, his ABI increased from 0.47 to 0.85. So he had fairly, and I'll say fairly good perfusion, not ideal. Certainly with diabetic distal arterial disease, this was still a very, very challenging wound. A1C, again, uncontrolled diabetes with a very high A1C, referred for hyperbaric therapy. So this is kind of one of those, this is one of our patients who has a lot going on, a very, very challenging patient. Now, when he first came in, I did eventually do a wound culture. And I mention this because I used not just your standard swab, but I used a PCR with next-gen sequencing, DNA sequencing, which ended up showing positive for staph, strep, and a fungal element, which I did not expect. And this is, one of the beauties of using this next-gen sequencing and PCR versus your standard swab, which likely would not picked up that species. So I did put him on doxycycline and ketoconazole PO, and that had a dramatic effect. The patient actually responded instantly after getting this. So that's kind of where I look at a wound that's likely, definitely bacterial challenged. And by using the antibiotic choices driven, suggested by DNA sequencing, made the right decision and actually had a very positive effect. So my plan with this patient was alternating disposable negative pressure wound therapy, which I do very often. I use disposable NPWT kind of off and on in between other interventions. So I kind of use it synergistically, but I also use my AG-oxy nitrate dressing, my gelling fiber dressing, as well as collagen ORC and silver. So let's kind of follow this through. This is when I first got him. So obviously a very, very necrotic wound, no granulation tissue. This is a challenging wound. So after 2 weeks of local care, I felt pretty positive about this. This was sharp debridement. I used, the wound was very desiccated, so I like to use honey just to kind of hydrate the wound. And so I 2 honey alginate dressings in 2 days, kind of brought back that a little bit of moisture to the wound. And then I moved on to the silver oxynitrate gelling fiber and also disposable negative pressure. So 3 days of disposable MPWT, maybe a weekend with the gelling fiber, and then back to the disposable negative pressure wound therapy. So after 2 weeks, wound's looking pretty good. Certainly much more improved. We're seeing a little bit of dull granulation tissue, but we're trying to rebuild this extracellular matrix and reduce the amount of non-viable tissue. So the measurement at this time, 6 by 2.3 by 0.5. This is after 3 weeks. So this is 3 weeks after that picture I just showed you, still using disposable negative pressure, silver oxynitrate, and I actually used 1 placental graft. So now you're seeing contraction of the wound, certainly much better looking granulation tissue. We're still working on with debridement, trying to remove some of that fibrin and some of that fibrous tissue. But then at this point, I went for 10 straight days with silver oxynitrate. And what I wanted to show you, even though, as I'm going to show you, the outcome wasn't ideal, from those 3 pictures, look at the quality of the wound bed and the size of the wound going with those 10 days of silver oxynitrate. The PAR went to 53%. Obviously, we're not on the 50% by 4 weeks, but certainly making very good progress. And I was really confident with this patient, but unfortunately, as I probed the wound bed, I found that I had a positive probe to bone with my my metal instrument. So unfortunately, after getting a radiograph, we found out that he had destructive osteomyelitis of the base of his toe. And the podiatric surgeon, the referring surgeon, decided appropriately to just move on to a transmetatarsal amputation, which he healed very nicely. So unfortunately, a lot of work that went for naught, but just showing the effectiveness of AG+3. And again, this is really in a very difficult case. We saw a very positive response from the wound bed. So this is kind of where we started, and that's where we got to. So I think without this complication, I think this patient, I was very confident I would have been able to get this patient healed. And that concludes our presentation. Thank you.